Good evening and welcome to our clinical seminar for tonight on differentiating bipolar disorder and borderline personality disorders. I'm lucky tonight to have two wonderful guests with me. But before I introduce them, I would like to share a little bit of information about the Children's Mental Health Resource Center with those of you who may be new to our work. My name is Elizabeth Errico, and I'm the Executive Director of the Children's Mental Health Resource Center. And our work focuses on bringing information about children's mental health, mental illness, mood disorders, bipolar disorder, and its newly identified phenotype, which has been dubbed fear of harm or FOH by researchers. We work with families to provide them with information, resources, guidance, and support as they travel the sometimes tricky path of getting their child the treatment that they need and the accommodations that they need to excel at school. We also work with providers of all kinds, from occupational and speech therapists to teachers to mental health providers to physical health providers like pediatricians. We work with psychiatrists and psychologists, social workers, LMFTs, you name it. If someone works with families, we work with them in order to help them have the information that they need to provide treatment that's research-based for children who are struggling. In part of what we do to fulfill that mission is to have these webinars and clinical seminars each month. We tackle different topics related to children's mental health, their life at school, and the diagnoses that we focus on. Tonight, we are going to be focusing on differentiating bipolar and borderline disorders from one another, because they have a lot of overlapping symptoms. And so we've brought together tonight two experts to be with us. The first is Emily Williams. She is a mental health provider who specializes in borderline personality disorder and its treatments. And she is here with us to talk about borderline personality disorder. And we also have Jennifer Sevick, who is a licensed clinical social worker and CMHRC's clinical director. Her expertise lies in mood disorders and specifically bipolar disorder. And so tonight is going to be a conversation amongst the three of us talking about the similarities and differences between these disorders and how providers can tell the difference and how they can provide effective treatment depending upon which diagnosis is most likely. So now I would like to invite Jen and Emily to join us on screen so that we can talk about the differences between these two disorders, which are so often confused. And so I want to start our conversation tonight by talking about some of the misconceptions that exist around these two disorders. And the first one that pops out always to me is that a lot of people seem to think that you just can't diagnose either borderline personality disorder or bipolar disorder when kids are young. And by young, I mean really anything under 16, 17, 18 years old. And I'm wondering if you all can talk with us about what that really means in practice when it comes to the diagnosis that you specialize in. So Jenna, I'm going to start with you and on this, and I'd like you to share your thoughts.
Yeah, so as you said, that people widely believe that it cannot be diagnosed in childhood or adolescence. And the reality of this, it's just simply not true. Bipolar disorder is highly heritable. And so we do see that children the reality is that there are statistics that show that it happens in childhood as equally as often as it happens for adults. And so we need to keep that in mind, that when we're seeing symptoms of bipolar disorder, that the likelihood, if they have a family history, is that we need to be looking at, you know, is this child living with a mood disorder?
Emily, what are your thoughts about this when it comes to borderline personality disorder? Oh, Emily, I think you're still muted.
Okay.
There we
Yay.
go. Yay.
I think for a lot of people, and clinicians that I've talked to before, they have a really hard time diagnosing BPD in adolescence because of the idea that, your identity is not very stabilized until after adolescence. However, some of the research shows that like it's almost like 3% of the adolescent population does have borderline personality disorder, and a large number of the people that end up in the ER or have suicidal ideation have borderline personality disorder in adolescence. I think it's very important that we do look at these diagnoses so that we're getting people to the right treatment in order to be able to manage some of these things, especially as we know, like the rate of suicide among our adolescent population is growing. So like looking at these things is like key and super important.
And so I would imagine that, like bipolar disorder, that in borderline, these symptoms are there's a stability in terms of symptom, but there may not be the same symptom presentation between children or adolescents and the adult population. Is that true?
Yes. So with the adolescent population, like I say the adolescents have baby bird syndrome, right? Like they have to have enough feelings of risk to jump out of the bird nest. And so, like, we've got that already happening in all adolescents. And then you add that to someone who is dealing with borderline personality disorder. And what we often see is a more intense version of what you see in adulthood. The relationship pieces of that is also typically more complicated because people have not fallen into stable relationships like they have more so in adulthood, where people are more often have long-term partners or been married or other types of things. With the teens, they're jumping from different relationships, as they should, trying on those different hats. But you see those relationships get much more intense than what you might see in more adult relationships.
There's also a misconception associated with both of these disorders that trauma is actually the cause of the symptoms, and that diagnosing either bipolar, which is abbreviated as BD, and by borderline personality disorder, which is abbreviated to BPD, that those diagnoses don't apply, that it's likely actually a trauma response. Emily, what do you think about that?
Well, there is a genetic component to BPD. People with BPD are typically born with increased emotional sensitivities, kind of like people with increased sensitivities to like allergies, pet dander, or something, right? Like you might have a cat, Elizabeth, and you rub your face all in it, and I might have one, and my face is dripping snot, right? Like we've got different sensitivities. People with borderline have increased emotional sensitivities, which just means that they feel them more intensely. They tend to last longer, and it takes them a lot more to get back to baseline once they have those big feelings. The thing where the trauma piece comes in is that there's a biology to it, and I think some people confuse the trauma piece is that what creates such the bigger emotions is that they meet these invalidating environments. So, like, there's a lot of things that can create invalidating environments. Trauma is one of them, right? So, a lot of times, people who have experienced trauma, they get that don't ask, don't tell, we're covering it up, this never happened, that kind of stuff, these invalidating statements. But that's not the only thing. Like, sometimes it's a goodness of fit situation where maybe you have a parent who's super high energy, but then you got somebody who's low energy, and that's not validated. What seems to be consistent across what creates some of the bigger intensity is that chronic invalidation. When I talk to people about this, I always say, like, how a lie detector test works, like there's that stress response that comes with it. So if you have a big emotion and somebody tells you, that's not your emotion, you shouldn't have that emotion, or you minimize it, then you have the stress and then the emotion. And I don't know if y'all ever been stressed and had big emotions, but does not typically go well, at least not for me. But it just gets bigger and bigger. And then as it gets bigger, there's more invalidation, and that's where you see some of the escalation.
So it sounds like you're saying that there's sort of an interacting relationship between borderline personality disorder and trauma.
Yes.
Yeah. Jen, can you talk a little bit about the idea that bipolar disorder is actually a manifestation of trauma?
Yeah, so the reality is that we touched on that before, is that bipolar is a highly heritable illness, and it's about 60 to 80% when we're looking at heritability. And the reality is that there are many, many people who do not consider themselves to have experienced trauma, and they still live with bipolar disorder. And it's hard for people to really go, well, how can you be that sad or that depressed and have not experienced trauma? And that's because it's a biological reaction to what's happening physiologically in your brain. And that's really hard for people to really wrap their minds around, that you can be depressed and there seems to be no reason. But there is a reason. And the reason is it's because it's biological.
So while Emily sort of presented this idea that there's an interaction between trauma and borderline personality disorder, Jen, what I think I'm hearing from you is that that bipolar disorder and trauma could be happening simultaneously, but that doesn't make them the same thing. That doesn't make trauma the cause of the bipolar, but they're not mutually exclusive in any way.
Correct. You can have both, but lots of people experience trauma and do not live with bipolar disorder. And so there are lots of people with bipolar disorder who have unfortunately experienced trauma, because if we live long enough, we all encounter some adverse experience in life.
So, it sounds to me as though, you both are presenting ideas that are already starting to like function on parallel tracks, that are highlighting some key differences between them. Jen, I keep hearing you talk about the biological, the physiological. And Emily, I hear you using the word relationships over and over again. Emily, can you talk a little bit about that aspect of it as a difference from bipolar?
Okay, yeah. So one of what I know is the key differences in the borderline and the bipolar is that, like, a lot of the behaviors that are associated with borderline personality disorder are relational in nature, meaning that there is a function to some of the behavior, and it's typically to kind of garner some sort of relational experience, whether that is to feel cared about, or if it is to feel like somebody sees their pain. But it is related to almost like a witnessing of some sort.
Jen?
Yeah, so regardless of the relationship that you have with a person, these mood episodes are going to occur. And you really depend upon those trusted people in your life to help you with managing and pulling through, and having that support to be able to weather these mood episodes. But it's not the relationship that triggers mood episodes. And so I think, if I understand Emily correctly, that the relationship sometimes can, am I understanding that correctly, that the relationship sometimes can trigger these episodes?
Yes, in fact, we even say the treatment for it is a relational treatment, in that like we're working through some of those relationship difficulties. For people with borderline, there's an intense fear of abandonment that is typically at their very core, or an intense sense of emptiness. And they're like reaching to kind of fill their cup up because they feel that emotional deficit, and the people in their lives help them to get that. So when they drop below their threshold of like their emptiness cup, like there are behaviors associated with trying to get that back. Or if they fear the loss of a relationship, that's often a very big trigger for their behaviors.
So, so one of the things that I'm hearing you both talk about here is that, uh, Jen, you keep using the word mood, and Emily, you keep using the word emotion, and that doesn't seem accidental to me. Can you talk about why you're using those words specifically, Emily?
Sure, yeah. So, borderline personality disorder has pretty intense emotional dysregulation. And what I mean by that is that, like, when I think about the difference between mood and emotion, is mood's like the climate and emotions like the weather, right? Like it's the smaller version. And so, like, usually when we see the emotions that show up in individuals, like it makes sense, right? Like the context, like if a boyfriend broke up with you, you would feel sad and upset. But the dysregulation piece is that the emotion is way more intense than what you would see in the average person. And when you see that, some of the behaviors to make that emotion go down may be kind of more than what you would expect from the average person too. But there's a difference, right? It goes up and it goes down and then it's gone. Like it's temporary.
Yeah.
Jen?
And so with mood episodes, what you're really experiencing is energy episodes. So you can have low energy to absolutely no energy, or you could experience too much energy. And when we have low energy, we see that depression creeping in. And then when we have high energy, we might see risky behaviors and the things that you would associate with mania, the increased speech, the physicality of the body just kind of like going on Zoom. You can, for some of us, a lot of people say you can almost feel it. You can feel how sad they are. You can just feel like how much energy they have and how exhausting that is for the person who's witnessing and observing those things. So when I look at mood, I also want to look at it as more of what is their energy, that it feels like that's happening to their brain and their body.
So we have some great questions coming in that I want to get to. Two are around the same thing, wanting to know if it's possible, and if so, how common is it for someone to have both borderline and bipolar disorder? Do either of you have information on that?
As well, I don't know what the statistic is around that, but I can say that I see it frequently. Because if you think about people who have bipolar disorder, if they have major mood experiences and they're in a family that doesn't validate that or doesn't work with that, or, baby says like you don't need medication, which is some of the things that I hear, then you can imagine that chronic validation would be there to kind of create the circumstances for borderline to kind of develop because the emotional sensitivities are already there.
Interesting. So again, can co-occur, but don't have to.
Right.
Jen?
Yeah, there is a percentage of individuals who do live with both, but it is very important that when you're looking at, can this be both? There's literature out there that suggests that you really need to treat the bipolar piece of this, the mood stability of that. And then after they have been stable for a while, if those traits are still persistent and then they're still there, then you know that it's both of those things together. And so I know people often want like a quick diagnosis, but it's a process. This is not a quick thing where you can just go, okay, I see this. Oh, it must be both of them. It really takes a long time to kind of tease out, do we have both of these present?
So it sounds as though what you're both saying is that, you treat the mood instability, and then you can see whether or not the big emotional dysregulations are continuing to occur, and then you move on and say, okay, well now let's treat the next piece of this, but that they really have to be treated sequentially at first, rather than sort of trying to attack them both at the same time. Is that accurate?
Yeah, but
I
I would add that like we want to meet people where they're at. And so what they're dealing with is what they're dealing with. But when you're talking about bipolar disorder, when you're talking about mania, or somebody who is experiencing major depression, if they can't show up and attend for you during the session, it's hard to get a lot of things accomplished. And at the same time, I think if they're having relationship issues, if they're living with bipolar disorder, and that's the thing that they're having the most difficulty in that moment, and that is going to impact their quality of life and their ability to function, then you need to address those things.
Um, Emily, what were you going to say?
I was just going to say that I completely agree with you on treating the mood disorder first, because the approach to borderline personality disorder is behavioral in nature. And when you have mood shifts coming up, it's really hard to get the patient stabilized enough to be able to look through a chain of events that would have caused a major emotion. And so if they've got these shifts happening, then like we can't attribute it to like what is the function of this behavior and kind of look at that because it's influenced by mood as opposed to some kind of event or something else going on in their life.
Emily, I love the way you explained that, because it really speaks to the heart of something that we talk about a lot, which is that mood disruptions, because they have this biological chemical underpinning to them, can't be treated with behavior modification interventions. And what you've said really highlights that as a distinction, but I don't want to jump ahead of myself because we will get into treatment in a little while. But we do have a question here about whether or not one disorder can evolve into the other. Can you be diagnosed with, say, bipolar as a child, and then as a teen or adult have that diagnosis switched to being borderline personality disorder, or the other way around? Is that something that you see or think is likely?
I'll start with that bipolar disorder is a lifelong disorder. And so once you have been accurately and appropriately diagnosed, it is a lifelong disorder that is, and I want to stress it's manageable. So this is a very manageable illness, but it is a lifelong illness.
Yeah, I said, I think that there are a lot of really overlapping symptoms with the two. And you're talking about providers who have people in their office, sometimes psychiatrists, for 15 minutes, or a therapist for an hour out of the week. They can't see all the dynamics that are happening outside of the session or the practice. And sometimes people don't want to report to all of the things that are happening in their lives, especially because of the stigma of both of these disorders. And so I don't know that they change over time as much as more information comes in and people have greater ability to accurately diagnose what is happening for the person.
Yeah, I agree. It's developing a relationship with that client and understanding them over time. And so you get more and more data, more and more information that you can then use to go, okay, now I see the picture of what's been going on.
And so there's another question here that I want to get to, which goes back to the issue of trauma and attachment. Is that someone's asking, do children who are adopted and have fear of abandonment issues have a higher prevalence of borderline personality disorder?
Um, I think that depends. I don't know the exact statistic on that, to be honest with you, but what I can say is that those individuals who are placed in homes where maybe the goodness of fit is not there, which is more likely with adopted kids, right? Because if you're from the same genetics, the likelihood that you're going to have similar personality types or genetics and things that kind of go together is higher than if you're from a whole different family. And so the likelihood that there's a mismatch of ways of being is higher with adopted kids. And like if there is an invalidation of the desire to know their birth family as a very genetic, very basic raw need that can also come up. And I think it's very individualized, and I think it has a lot to do with the validation in the family as opposed to like the adoption piece.
Interesting. Jen?
Yeah, I like Emily how you phrase that because you know I'm very familiar with adoption, and I agree that it's goodness of fit. But what I like about that explanation is that you're not placing blame on parents, that you're not saying you caused trauma, there was abuse that's going on. It's more about that goodness of fit. And I absolutely agree with that because what I hear I think sometimes from other clinicians is the assumption that there has to be abuse, there has to be neglect, there has to be something behind that. When you can be a really good parent, it's just a mismatch or goodness of fit between personalities.
Yes.
So we have a question here. Someone is asking us to repeat something that we said earlier about bipolar disorder and how it's treated. We will get into the treatment piece in more detail, but what we said there, what I said was that bipolar disorder symptoms cannot be treated with a strictly behavioral approach, generally speaking. The behavioral approach can come in to teach new skills and habits after the mood disruptions have been stabilized. But mood stabilization doesn't occur through behavioral interventions. Mood stabilization occurs through other interventions. And so we will get to that in more detail shortly. We have a question here, and it's not specifying whether it's asking about borderline personality disorder or bipolar. So we'll answer for both. But asking, do you find clients more often than not are not forthcoming with their providers regarding their symptoms? Emily?
No, I don't really have that experience too much. I think but my specialization again is like chronic suicidality. So let me give a little caveat on that. In that I know that many of our patients know that you mention the word suicide and they may end up in a hospital. And they know that very well. And so if we don't have the conversation, especially with chronic suicidality, that, here is when I would make that decision and here is when I would not. I typically try to avoid hospitalization because what we know with people with borderline personality disorder is it's often reinforcing for them. To have people to pay a lot of attentiveness to them or to get out of an environment that maybe does not feel very good. And so we try to avoid hospitalization because it, like if it is reinforcing, it increases the likelihood that suicidality is going to show up again. And so I think having those conversations with people ahead of time and letting them know, like, what does a contract for safety look like? What would be the expectations so that they do feel comfortable sharing information? Because I think that's one of the biggest barriers to people being honest about their symptoms is they are afraid of, like, are you going to tell my parents and are you going to send me to a hospital?
Mm.
Yeah, when I find that when you're working with the pediatric population and teenagers included in that pediatric range, then you're working very closely with those parents, and those parents are going to be rolling off those symptoms that by that point they have seen for years. And so they're so concerned. They want answers that in some cases it's almost like they just can't get it out fast enough. And so it's almost like they overwhelm you with all this information because they just want answers and they want you to know what their history is and to tell them, please, help me. What do you think that this could be?
Yeah, and I was just going to add to that as a mental health professional myself. It also seems to depend a little bit on what is bringing that person into the therapeutic relationship to begin with. If someone is there because they don't feel well and they want to feel better, the incentives to misrepresent their excuse me, to misrepresent their symptoms is very low, because they know they won't get help if they're untruthful. But when they've been coerced or forced or had some kind of consequence imposed if they don't go, that actually incentivizes the opposite. And so I always think of it in terms of who wants the help. If the person wants the help, that's going to influence that therapeutic relationship and how it develops and how the work gets done. But if the person is being told they have to be there because someone else thinks there's something wrong with them, that's going to significantly decrease the degree to which that therapeutic process is going to ultimately result in meaningful change. And that's just my take as a clinician.
Now, I do see where parents are very protective of their children and they don't initially tell you everything. And that's when there is aggression. And so that's when things get broken in the home, where there are holes in the wall, furniture destroyed, maybe sometimes in a mood episode where a parent might get hit or hurt or hair pulled. Parents are very reluctant to share that information because they don't want you to, they know their child isn't a bad kid. And so they're very protective of that. And there are ways in that interview process and over time to help that parent feel safe and to know that this is a judgment-free zone and that's information, that's data that helps us to arrive at the most appropriate diagnosis.
Mhm, mhm. So some folks here are asking about pathological demand avoidance disorder. And I'm just going to say that we recognize that this is a disorder that is out there. People are asking when it's going to get into the DSM. I have no idea because we don't work with that disorder, and I would not want to say anything that would suggest we knew more than we do. But what I will say about pathological demand avoidance disorder is that um, all of the disorders in the DSM have criteria associated with them that are considered normal human experiences and behaviors. What puts them into a DSM diagnosis is how they cluster, how intense they are, how frequent they are, and the two most important factors for it to be that normal human experience to be considered a criteria for a disorder is it causing subjective distress, and is it an obstacle to expected daily functioning? And so PDA, I'm sure, does both of those things. It may belong in the DSM, but it's a very complicated process in terms of how things get into the DSM. And so I couldn't even begin to speak to that. I will also say that many of the disorders in the DSM have overlapping symptoms, which is exactly why we're doing this today, differentiating bipolar disorder from borderline personality disorder because of their overlapping symptoms. We do this with bipolar disorder a lot. We also have a clinical seminar where we differentiate it from ADHD symptoms. And so what happens is when there are a lot of overlapping symptoms between diagnoses, the most important thing to do as a clinician is to conduct a thorough differential diagnosis where you are considering the possibility of all of the diagnoses that contain that symptom as part of their criteria list, because it is only possible to rule something out when you have first considered whether that it may be a possibility. And so we would encourage anyone who thinks that their child may have pathological demand avoidance disorder to pursue assessments to determine whether or not that is accurate, but not to pursue that at the expense of also considering borderline personality disorder, bipolar disorder, or any other disorder that those symptoms may match, because it's only through that very thorough and extensive process that you're going to get to the right answer. And we tend to discourage parents from seeking out a specific diagnosis, rather seeking out someone who can help them figure out what the right diagnosis is, regardless of what it is. So that's the answer to that question. There are questions here that I think are really wonderful about differentiating age-appropriate behaviors from the criteria of the disorder. And so I think that now might be actually a good time for us to jump into talking about these overlapping symptoms that borderline and bipolar both have, that may also be a part of, as we said, pathological demand avoidance, reactive attachment disorder, and lots of other ones. But for right now, we're really going to just focus on borderline and bipolar. And so the overlapping symptoms that are often identified, and we'll go through each, include things like explosive, angry, or irritable episodes, self-harm behaviors, suicidal ideation, impulsivity, nightmares. And so let's start with these explosive, angry, and excessively irritable episodes. Emily, can you talk us through what those look like in terms of borderline personality disorder?
Yeah, so typically an explosive anger episode is a result of a perceived kind of loss or threat or something. There's usually like a feeling, there's something that has happened and then they have a reaction to it. So it's like this emotional shift that happens and then based on something that has occurred,
Okay,
if that makes
Jen?
sense.
So we touched on this before that there's this energy shift that is occurring within the brain. And so it's shifting that mood. And so you can see when we talk about explosive or angry or irritable, episodes, those can come from if you are experiencing depression. Most of us are familiar with if we don't feel good, we might be a little bit snappy. This is more so. So that increased irritability. But we can also see with mania, we can have irritability, we can have, energy to have rages. We talked a little bit about that there could be some physical aggression that comes along with this too. But this is not their, I want to emphasize that this is not their normal or usual self.
Mhm, mhm. Um,
Whereas with borderline, there's like a hypersensitivity to criticism a lot too. And it's like ongoing kind of irritability. Like it's just always kind of ever present. Like when they perceive somebody does not approve of them, or there's some level of criticism, or somebody's going to leave them, or they perceive some level of rejection.
mhm. Interesting. Um, so self-harm, which of course leads into sometimes concerns around suicidality. With self-harm, how do you typically see that in borderline personality disorder?
Self-harm for people with borderline personality disorder usually has some function. It's kind of operational in nature. Typically what we see is they're trying to get a need met of some sort. And again, we go back to relationships. This typically goes back to relational uh, prompting events is what we call them, like the thing that set us off. And so typically what it looks like is maybe they want people to notice how much they have hurt them. So it's almost like a punisher, right? Like this idea of like, look what you did, look how you hurt me, look how how much I'm hurting because of what you did. Which sometimes I think goes into my next point, and I'll tease that out in a second too. But the other thing is kind of this sense of like, I really want somebody to rescue me. I want somebody to come in and save me from what's happening here. And what I think this is, and this is my own little caveat in my head as I can speak to, is that like I want you to see, I want to punish you so that you feel guilt. We have, like we're almost, we want to repair. That's what we want, and that creates connection. And so, and also with if I self-harm, then we also get connection too, because then I get a rescuer. And so I think it has to do with like trying to reach out for the relationship that they really want, because again, it goes back to like I'm intensely afraid of being abandoned and I feel relationally empty, and I've got to figure out a way to get that cup filled back up.
Jen?
So when we're talking about self-harm and bipolar disorder, it's this intense pain that is internally driven, that things are never going to get better. I just hurt so badly. I just feel, maybe so worthless. And it is about punishment, but it's about hurt, just wanting to fix the self versus like when I hear Emily talking, it's look what you have forced me to do or driven me to do, versus with bipolar disorder, it's I'm so deeply depressed. I'm so deeply hurting inside that this is just the way to show that.
It sounds as though you're saying there's sort of a difference in directionality, that if with borderline personality disorder, the self-harm is intended to communicate something to someone else, whereas in bipolar disorder, it's very much simply a reflection of what's happening internally.
Correct. Yeah.
Yes.
So once again, I'm struck by the fact that, and as we've discussed when we talk about the differentiation between ADHD and bipolar, that it is really not the symptom itself or the sign that matters. It is what is driving it and where it's coming from. And that's not something that can often be determined on a checklist of assessments. That's something that can only come through that clinical exploration in session with the person who is being assessed. Um, so I'm interested in how that relates to suicidal ideation, which can be a major concern in both of these disorders. I think that bipolar disorder may have the highest suicide attempt rate of any mental illness, and it is not something that is rare in borderline personality disorder either. So, Emily, what does that look like when we're talking about someone who's living with borderline personality disorder?
Oftentimes, like with the BPD patients, they'll have gone to hospitals over and over and over and over and over again, because it's chronic. There's kind of like this sense that like this feeling like, they'll be sorry when I'm gone, and it's still that same kind of operational kind of piece to it. And I should differentiate too that, like, so a lot of times people with BPD will self-harm, but they won't tell anybody. The message that they're sending to somebody isn't always completely overt either. Sometimes it's like, I want them to eventually know. So like, it's not always very clear. It can be kind of underneath the surface too. And there is this sense of like how being hospitalized will affect other people. And there's also, like, for a lot of people with BPD, there's like this really intense self-hatred that they feel, and they want to like get away from that experience. But they also want a response from other people that tells them they're not as bad as they think they are. Probably at the core of it is that they just want that feedback that they're okay, but it doesn't typically last very long, even when they get it.
Jen?
Yeah, so unfortunately, with bipolar disorder, you had mentioned a statistic previously, and I think the rates between borderline personality disorder and bipolar disorder, they may be comparable, but I've seen where it's been slightly higher for bipolar. But what's really off the charts is the completion rate for people who live with bipolar, that they're more likely, unfortunately, to have higher completion of suicide, and to people to die from suicide. But unfortunately, it's also seen by these individuals as a reasonable solution to the pain and the true suffering that they're experiencing day by day. It seems to them at that point like this is a reasonable answer to what is happening. And so sometimes they see it as the kindest thing to do for themselves. And unfortunately, sometimes they see it as the kindest thing to do for their family because they don't want to be a burden to them, that they don't want you to watch them suffering anymore, and they don't want you to have to go to all the lengths that you have been trying to go through to try to help them.
So that's an interesting distinction that I'm hearing the two of you make. With Emily, you're again so consistent. It seems very obvious now that we're really digging into it, that it's relational, and it's about sort of sharing that pain and that need to have someone to come rescue. Whereas with bipolar, it's almost the opposite. It's almost that the pain is an attempt to not make anyone else have to deal with their pain any longer. Um, but I want to just highlight, in case anybody gets the wrong impression, we're certainly not saying that in borderline personality disorder that suicide attempts aren't real or that they shouldn't be taken seriously. Emily, do you want to say anything about that?
Yeah, absolutely. So they are very real. I think it's very the motive behind it, because like if I really need it, well, if the person really feels like I really want them to have that show of care, there's almost like this feeling like once I'm no longer here, then they'll know how much I how important I was. And those thoughts, like it doesn't like register really that like gone is gone. And so like it is just as real. In fact, oftentimes what we see is that like they very much want others to tell them that they love them, they care for them, they want to be there. And so like sometimes like the lower level behaviors no longer get that response from people, because like maybe they've been doing it for a long time, and so they'll start to escalate the level of dangerousness in order to get a bigger response, which gets more and more dangerous over time, because they're not getting what they want. In fact, even when we start working on this in therapy, like the behavior bursts for that, like when we stop responding to these pleas for help, this plea for rescuing, like we have to put some safeguards around the escalation, because it's going to happen. Um, because that's just what happens when people are no longer getting the response they need from their behaviors. They're going to up the ante.
That's very clear. Thank you for putting it in those terms. So we have actually a bunch of questions here about impulsivity, and that ties into the next symptom that we're talking about here. And folks are asking questions like, how is it impulsive in bipolar disorder? And if so, is it does the impulsivity factor influence the outcome of the interactions with others, that other people may be impacted by those impulsive behaviors? So Emily, why don't you talk us through impulsivity and what it's really caused by in borderline personality disorder?
So I think it goes back to that same like emptiness, relational experience, those intense fears of abandonment. So if there is information out in their environment that indicates that there's some risk of rejection, there is typically some impulsive behavior. So like I've seen with teens like engaging in very risky sexual behaviors because they're afraid of losing the attentiveness, even if that attentiveness was only there for 10 minutes. Like there's something there about like I've got to keep a hold of that for myself. Or like if they sense that a friend is starting to back off, they might impulsively like even reject the friend so that they can spare themselves the rejection. Like it's typically, even though like sometimes it's substance use or other types of things, it's usually, if you really look at it and boil it down to the pieces, it's about staying connected to somebody or avoiding disconnection from somebody.
I love the way you said that. It's about avoiding disconnection or maintaining connection with someone.
Yes.
Yeah, so if we go along those lines for your example that you gave for impulsivity with like risky sexualized behavior, we see that with adolescents and teens living with bipolar disorder. We have that increased impulsivity, that increased energy, and so they're engaging in these very risky behaviors because they often have these intrusive thoughts or compulsions that they need to follow through on. And sometimes we call that mission mode. And so there's that absolute drive, stemming actually from the amygdala, where we have like that hypersexuality piece that's going in through. And so it is not necessarily due to any type of relationship. They're not seeking a relationship. They're fulfilling a need that they absolutely have to have filled. And so, but we also see sometimes impulsivity with depression as well. And so we have these unwanted, intrusive, sometimes just disturbing thoughts that are occurring, and they just want to try and get rid of them. And so whatever thought pops into their head of like, this is how I'm going to get rid of it, then they may very well follow through on that.
So there's a question here about impulsivity and how it may relate or not to suicidal behaviors, ideations, and the rest. Is that something that is a factor in suicidal ideation with bipolar and with borderline personality disorder? Is impulsivity a piece of that, Emily?
For borderline, oftentimes, like we'll see with the self-harm behaviors, that's a definite piece of that, right? So, like oftentimes, like they'll have a big feeling, they want it to like go away, or they want like to communicate to somebody that they're feeling like this terrible. And so the impulsivity goes like, well, even though I know this is not going to be good for me in the long run, I'm going to self-harm. Oftentimes too is what you see in combination with that is there's an intense shame around that. There's an intense shame around the fact that they really want that connection to that degree, and that can often spark the suicidal ideation. So it's almost like this chain of events that happens where like they engage in a behavior to get connection, they feel really bad about themselves, which only makes them want to reach out for the connection more, right? And then like it's like this building blocks of how we arrive to this much bigger behavior to manage what's happening for them emotionally.
Jen?
Yeah, so I think we've all heard about cases where somebody has completed suicide, and we're very confused because we go, well, but they were okay. Like I just saw them the other day and they seemed happy, and what was happening? Well, unfortunately, when you live with a mood disorder and you live with bipolar, you forget those feelings of contentment, that you were okay at one point. You are deeply rooted in living in that moment. And so you remember not the good times, but interestingly enough, we tend to only be able to remember the bad things. And that is what drives that. And so if you are having that burst of energy or that burst of impulsivity that is happening, and you are stuck in one of those mood episodes, the likelihood that you could attempt suicide is pretty high in those moments. And so that's where that confusion comes from, because in teenagers they can rapid cycle, and so they could have had some good days, and then all of a sudden they're in a moment of despair, and you didn't catch that. We didn't see where that was coming from. It seems like it came out of the blue.
Mm. Jen, I think you answered one of the questions that we have here, which is that in bipolar disorder, they're asking if the impulsivity is only seen during manic phases, but you're saying no, that they also occur during depressive phases. So the next overlapping symptom is nightmares. which I think not everybody thinks of as a symptom at all, let alone an overlapping symptom. Um, Emily, can you talk to us about what nightmares look like in borderline personality disorder?
Yeah, it's like nightmares can take on two different forms. Like sometimes when it's trauma related, it can be the replaying of the trauma or the other experience, but other ways that it shows up is that it is the what I call the emotional recipe. You'll see those kind of play out in their dreams. So like whatever they were feeling, those intense emotions, like the story will match that emotional recipe that they've been trying to process again and again.
Jen, what about bipolar?
So the interesting part about that is that, as Emily had mentioned, if they also have co-occurring trauma, you can see them playing out the trauma in their nightmares. And then we would want to look at, could there be a co-occurring disorder with like something like PTSD? However, something very different can be happening. And again, unrelated to any trauma or anything they've ever seen on a TV, anything that they've ever witnessed in person. And that is that often their content of their dreams can be very graphic, can be very gory, just, very horrific type scenes. Often they experience their own death in a very graphic and gory way. They cannot wake up from this, as most people do when they experience these types of things before they actually get into the accident, before they actually die or experience that pain. They're actually experiencing it while they're sleeping. And often it is about other people that they love and care about, and they see their absolute just horror scenes that are playing out to their loved ones, and cannot wake up out of this.
This is a this is really a fascinating distinction here, that that I think is really important for us to underscore, which is that if I'm understanding what you're both saying, is that Emily, you're really saying that nightmares in borderline personality disorder are the person's brain trying to process their experience,
Mm-hmm.
and that in bipolar, their nightmares are often completely disconnected from their experience, and that as a result, um, that may make it trickier when it comes to bipolar, easier to differentiate between these two disorders, but perhaps more difficult in the case of bipolar disorder for clinicians to be able to uh, feel confident that what they're hearing is not a report of a trauma, but that it is in fact something that is truly disconnected from the child or adolescent's daily experience.
Yeah, and the other thing that you'll see is that teachers may have a call home about their writing work that they've done or their artwork that has been submitted, that it just seems so graphic and gory and disturbing. And so instead of processing what happened during the day in their dreams, they're actually in the daytime processing what happened in the nighttime and trying to get that out. And what we see is sometimes they don't remember the actual dream. They'll say, yeah, I had a nightmare and it was really scary. And, I don't know how often I have them. When in reality, they could be actually having them every night. And it goes back to like these sleep wake cycles where parents will go, but they're sleeping. Um, well, their eyes may be shut, but they might not be going through all the steps of all the different cycles and stages of sleep in the appropriate amounts of time that they should be, and they might be stuck longer in others and moving faster in other phases. And so it can look like they're sleeping, but they're not getting the quality and the rest, the sleep that they need, and the content of what they're dreaming can be very disturbing and cause trauma. That's the other part of this is when these graphic nightmares happen, and sometimes they've been happening for years, and nobody has picked up on this. And it's the dreams that actually cause post-traumatic stress disorder.
So, what I want to do before we move into talking about treatment, which includes medications and therapies and lifestyle interventions, I want to just follow up with a few things that have been brought up in the questions that relate to sort of identification and symptom presentation. And so I'm going to list a couple of things and then ask you all to just answer based on your knowledge and experience. So there's a question about how race and culture impact the frequency of these different diagnoses being assigned either correctly or incorrectly. There's a question as to whether reactive attachment disorder can be a precursor to borderline personality disorder. There are questions about menstrual cycles as to whether or not they impact either emotional dysregulation or mood dysregulation. And a question here about collecting things and whether that is a symptom of either or both of these disorders. So, feel free to jump in here with any and all answers to any of that stuff as you see it. Just go ahead.
Well, I'll start with menstrual cycles, in that we see the information and the research is pretty clear that for women and for teenagers or anyone who is menstruating and lives with bipolar disorder, that it does make it a little bit trickier in terms of managing those moods and with medication pieces. So there does seem to be a relationship between PMDD and bipolar disorder. I know that we see that a lot at CMHRC from parents reporting that with their teenagers, and trying to be able to coordinate with all of their providers to get that taken care of.
So just to build off of that, on the other side with BPD, that I don't know if you remember that I mentioned at the beginning that has like a biological emotional sensitivity that is just more. And I mean, for a lot of women on their period, let's be real, like there's emotional sensitivities attached to that. So we're looking at a combining effect. So it absolutely will impact some of the emotional dysregulation that occurs during those periods. In fact, we'll see more intense periods or more intense behaviors during that time. And we do see some level of like co-occurring PMDD as well with borderline personality disorder.
So what about ideas like or symptoms like collecting things, or maybe hurting animals, or other symptoms like that?
One of the stereotypes or myths that's out there, and why parents are so very protective of their children, is this idea that these are very aggressive or mean kids. And so I just want to preface this with the vast majority of the time in between mood episodes, these kids are described as and teenagers as being the most loving, the most loyal, the kindest, most compassionate, like the funniest and creative, all these good things. And so when aggression happens, it's typically because when they're having a mood episode, you happen to be there or in their way. And so we do a lot of safety planning in terms of how to minimize those things. But in terms of deliberately, like seeking out to hurt someone, and Elizabeth, you correct me if you think that this is not correct, but I just don't see that as being like a core trait or a core symptom of any teenager or child who is living with bipolar disorder.
Yeah, I would agree with that assessment, Jen, that with bipolar disorder, we see one of the differentiating characteristics that we're always looking for is remorse, regret, the desire to make amends, empathy, compassion, um, actually being extremely sensitive to other people's moods and feelings. And so we don't generally see intentional harm to animals, intentional harm to others as a part of bipolar disorder. In that way, it may occur in the course of a dysregulated mood disruption, but it is not calculated, and it is often met with serious remorse afterwards. Emily?
Yeah, with BPD, one of the key characteristics of people with BPD is that they actually have like really intense empathy. Like it's super, like they are some of the kindest people. They are very attuned to other people's emotions. And can they, I know in the teenagers, they're always calling them the therapist friend because they love to also get in there and just kind of like empathize with others. They, I would probably say it mirrors a little bit of with the bipolar, like you guys were describing, in that like, can it happen? Sure, but it's not as an intentional effort, a malicious effort. Their sense is really to more focus on harming themselves than it is other things outside of them.
Okay. All right. Is there anything along the lines of the question about racial or cultural impacts in terms of diagnosing or misdiagnosing? Jen?
So this is what's fascinating to me is that in all cultures, at the same rates, consistently, we see bipolar disorder. And so regardless of the country, the culture, the ethnicity, it is holding steady at the rate in which we see in the population bipolar disorder. Unfortunately, though, there are, I know in the United States, African Americans are more likely to be diagnosed with schizophrenia disorder rather than bipolar disorder. And there's some symptom overlap that can happen there too. But they're just more likely to be given that diagnosis, or they're more likely to be seen as living with conduct disorder, oppositional defiant disorder, antisocial personality disorders. So it is really important to be able to recognize the symptoms of bipolar disorder, so that we can accurately identify that, because this is manageable, and to be able to help them on the right path for treatment.
Mm-hmm. Emily?
So with borderline, I can say that there is 75% of people who are diagnosed with borderline are women. That does not necessarily mean that only women have most women have borderline. What often happens in the male female is that males are more likely to be diagnosed with PTSD or other types of things related to trauma-based stuff. With the minority groups that we see, we do have a higher rate of like there's a greater concentration of suicidality and self-harm behaviors that often gets identified as borderline in our LGBTQ populations. Now remember, like borderline is a illness of chronic invalidation, which means like we as a society have certain groups that experience a great deal of invalidation, and they're more likely to show up. But what's difficult to tease out is that also in minority groups is a fear of mental health providers. And so it's complex. Like, I have no doubt that there's an overrepresentation in some of our minority groups, but we wouldn't know it because they wouldn't come to us to tell us. And there is also like what Jennifer was saying, in that they are in many minority groups, they're much more likely to be diagnosed with things like conduct disorder, antisocial personality disorder, and other disorders related to like um, aggressive type natures, which is always interesting. I think we have to be very mindful and careful about the way that we are allowing our cultural perspectives. And I say this because I don't think any therapist out there would be like, oh yeah, I want to label you just because of a minority group. Like, my hope is that the average person is good in nature, but I think we have those constructs that are coloring the way that we view symptoms, and I think we're missing out on getting treatment for a large population of people. I don't know that because the research it's hard to do, because we're like, again, we're only looking at men or females, and we're not getting as much information about some of the minority populations.
And I'll add that sometimes the pendulum swings the other way in an effort to not label someone. And this is how it's couched: as I don't want to label them. I don't want to attach stigma to them. So I'm not willing to diagnose this person with such a severe mental illness, particularly someone from a minority group, because they say, I'm just not willing to go there. I don't want to give them something that's going to follow them for the rest of their life. When in reality, what we can be doing is helping them to get onto the appropriate path for treatment and for care.
I want to remind everyone that if you have a comment or a question, please go ahead and put it into the Q&A. We are not responding to raised hands. There are just too many of us here today. So with the last 10 minutes or so that we have, I want to move us into talking about treatment, because now that we've been able to make it very clear that not only are there differences, but there are very fundamental differences in what is causing these symptom presentations in these two disorders, it makes sense that treatment would be different. And so, looking at one of the key differences in between bipolar and borderline personality disorder is, in fact, the medications that are used to treat them. And so, Emily, can you talk a little bit about sort of what the pharmacological interventions for borderline personality disorder are, and the rationale behind how they're used? And I will put out a caveat that none of us today are prescribers. We're not physicians or psychiatric nurses, but our experience treating countless patients who are undergoing psychopharmacological interventions, and our knowledge of the dominant current research in the area does allow us to speak to what the trends are in medications. So Emily, what do you see in medication use in borderline personality disorder?
A lot of my patients, they experience periods of depression. And so a lot of times you'll see them be placed on an antidepressant to kind of manage some of those symptoms and help them be able to do some of the behavioral things that we need them to do in order to be able to regulate their emotional states. Other things that you kind of see to manage, especially when the intense emotional dysregulation is disruptive to the family or an organization, like such as school or work or other things, is that they might be put on a low dose of antipsychotics to kind of manage some of the intensity of the rage, or some of the like intense symptoms of emptiness feelings where their behaviors are becoming more erratic in order to meet that need. Pretty much medications are there to manage the symptoms so that the treatment underneath the behavioral work can happen, because that's what actually moves it in a different direction.
Jen, what about medications for bipolar?
So the first off is that I know parents are concerned because when their child has been diagnosed, they're often under more than one medication. So we're not likely to see monotherapy or just one medication that is going to take care of all of the symptoms. And so the other thing is that mood stabilizers have proven to be the most effective treatment path in terms of managing mania and depression. And then you usually are looking at not only a mood stabilizer, but you're also looking at usually lithium plus that mood stabilizer is considered the gold standard for treatment. And you'll see lots of parents who say, oh, once that lithium was there, that was such a game changer. We hear that over and over and over again in the in the families that we work with.
So we're getting a lot of questions about treatment now, and so I want to really pivot into some of the other treatments that go along with it. And Jen, you used the term gold standard in terms of treatment for bipolar disorder. And we have been, as a community, as a mental health community, we've been studying bipolar for a very, very long time. And so we do have a sense of what is the gold standard. And I spoke earlier about the need for a rigorous differential diagnosis process when it comes to differentiating these symptoms from the different disorders. But Jen, I'd like to invite you to talk now a little bit about what sort of the gold standard is for diagnostic assessment, and to jump in and say, to answer one question that came in first, which is assessments for bipolar disorder are, in children and teens, two of the best measurements that you will find anywhere are the Child Bipolar Questionnaire and the Janie and Jeffrey Illustrated Interview for Children. You can find both of those on the website of the Juvenile Bipolar Research Foundation. They are both assessments that are designed to be taken at home. They do not need to be administered by a professional. Parents take the Child Bipolar Questionnaire, and it gives them, you can pay the Juvenile Bipolar Research Foundation for the scoring on that, and it will give you a readout. The Janie and Jeffrey Illustrated Interview for Children is for kids 14 and under, and it was at the time that it was released the only, I don't know if it's the only anymore, but in that case it would be the first assessment measurement that was designed specifically for kids to take. It's cartoon. It has all the questions are written out in cartoon format, and allows them to answer on a Likert scale. They too can have that scored. And so as clinicians, you can have your patients take those two assessments at home, bring you those reports and scoring, and those give you a great idea of what is not only what's going on symptom-wise, but its intensity, its severity, its frequency, because of those Likert scale readings. I would also mention that there are no medical tests, there are no blood tests for any of these disorders that we're talking about today. So if you're looking at medical testing, there really isn't any for that. And again, I'm going to put into the question and answer those two measurements that I just spoke of. But Jen, why don't you go ahead and talk a little bit about the gold standard and where the idea really comes from?
Sure. So Dr. David Miklowitz from UCLA, he writes about this in one of his books, which is the bipolar survival guide. And he talks about what they do and considers it really the Cadillac of diagnostic processes. And so coincidentally, or not so coincidentally, we actually practice that at CMHRC as well. And he talks about that it's not that common, but it should be. It should be the standard of care when you're doing that diagnostic process. And it starts with a structured interview that lasts about 1 to 2 hours, and you meet about 3 to 4 times. So that's quite a bit of interviewing process that takes place there. And then also simultaneously, you're gathering a very detailed history of development. Child inventories are being collected. You're having detailed family history that is also being gathered as information and data to be considered in the diagnostic process. You're reviewing medical records that are made available to you, and you're combing through all of those records and you're reading them, and not just medical records, even school records and notes and reports that have been sent home. And so then you're also wanting to consider all of the differential or comorbid diagnoses throughout this whole process. And then you're going to offer some feedback to the family after this. You're going to sit down and you're going to go through all of this, view all of the information to also make sure that you got it right as well. And so then from there, during this time, you're going to give them resources, information. You're educating them on these conclusions that you've come to agree that this is what we're likely looking at, and what are the best approaches to care at that point. So it's quite a lengthy, detailed process.
Yeah, we talk about treatment as a three-legged stool, that it has to, when you're talking about a serious mental illness, as opposed to, a temporary challenge, a serious mental illness almost always involves some kind of medication. It requires some kind of therapeutic intervention, and it requires lifestyle changes. And those things, when they're all put together, create a cohesive treatment plan that is not just a path forward, but it is also a safety net for when there's a problem with one aspect of that treatment plan. The others can protect that person from falling into some kind of, enormous setback. So, for example, if there is a time where, due to some extenuating circumstances, medication sort of ceases to be particularly useful, then you know that you have the therapy and you have the lifestyle interventions to support while medication adjustments are being made. Perhaps you lose your therapist, you move to a new place, you need to find a new one. While you're not getting that therapeutic intervention, you know that you're still maintaining your lifestyle interventions and you're keeping compliant with your medications, and that will carry you through the adjustment as you're changing providers. And so this gold standard that Jen has talked about is really applicable to any mental illness, not just the two that we're talking about today. And being able to engage in a comprehensive treatment plan that has been designed to address a specific diagnosis that has been given accurately, can be a real game changer. And it harkens back to something Jen said earlier, which is that these disorders are manageable when they are identified and treated. We have this idea often, and it's a misconception, that somehow one of these disorders is worse than the other, that one of these disorders is, if you're going to have one, you really should have this one, not the other one. I mean, all of that is really nonsense. That both of these disorders can be severe, can have significant consequences, but can both be managed if they're correctly identified and provided with effective treatment. So let's talk a little bit about the treatment that is used for bipolar versus borderline personality disorder. And we touched on this a little bit already, this idea that the, the behavioral interventions that work with borderline personality disorder aren't going to work with bipolar. And so, Emily, can you talk us through a little bit about what those behavioral and relational interventions are?
Yeah, so typically, well, the gold standard of treatment for borderline personality disorder is dialectical behavior therapy. That's typically the one most recommended. And so that treatment approach looks at helping a person like kind of get, like I said, breaking down what is happening during a major episode or intense emotional dysregulation to get the recipe that created it. And then behaviorally importing new skills into those things and kind of building a new way, kind of like you're on a train track and you're building a new path for the train to go in a different direction. There's also like behavioral principles involved that are like with positive reinforcement and creating aversives and other types of things to begin to shape the behavior. Like we talked about how it's very relational in nature. One of the first things I do is like when you self-harm, do you call your boyfriend right away? I need you to stop doing that, because when he gives you that love and concern, and I need to make a point to say that when these individuals with borderline personality disorder reach out for that connection, it is typically not with the idea that I'm manipulating this person. They don't have that kind of consciousness around it, because I think that's a misconception too, is that but what they get from it, when I say function and motive are not the same thing. What the behavior gets for them is that they give a lot of care and attention. And oftentimes, because they've heard so many people say you're being manipulative, that they won't want to talk to you about those things. And it's hard for them to even look at the function because they've heard it over and over again. But that's not, what they're explaining to themselves for the reason is not the same as like what the function of the behavior is, which is to fill their cup up. And so we're removing the reinforcers for the behavior, and then we're also adding new aversives in. New aversives would be like things that they want to add into the mix, not something that I put in. Like doing a behavior chain is what I call it. Was like if they have a self-harm incident, we do a behavior chain. They don't love a behavior chain. It's very detailed. And that's an aversive, right? And it kind of shapes some of that behavior. We also, because our patients, like they're very, very good at eliciting empathy, right? Like they're very good. They've needed it. And it's because their cup is so empty, because they really do have this emotional deficit that says like people don't care about me. And like that is from never getting those emotions mirrored back to them, that they doubted themselves and that they're looking for people's validation to say, yes, you're enough. And so when they do that, they are really good at eliciting that from people, including therapists. So, as a team, we have to have a collection of different therapists. With like part of DBT is having a consultation team to make sure that we are aware of these behavioral principles at all times, because there's going to be an inclination to want to rescue or help when you shouldn't be. And there's going to be an inclination when they're pushing up against you to get really angry and kind of like throw in an aversive when maybe it's not necessary. So like keeping those consultation teams to kind of keep an eye on that relationship piece, and also communicating the relationship, like what your experience is in the relationship with that patient. Like sometimes I tell my patients, like, I didn't want to come to work. I didn't want to do this session today because the last time you came in, you were kind of argumentative with me. So how do we repair that? Right? Like this, our relationship is our responsibility. And so you're bringing those things and you're saying, like, I'm not upset with you, but I'm feeling this aversion to what happened. So how do we repair?
Jen?
So we often read that the standard is cognitive behavioral therapy, but I want to put this out there that it's not the first step, in my opinion. Um, Earlier, I had mentioned that we have to meet them with where they're at, and where they're at is usually you have to develop a sense of safety. And so parents will say, I don't understand why I'm bringing them to therapy when all you're doing is coloring or playing games. And what you're doing is you're developing a relationship so that they can feel safe. Because most people who live with or are bipolar disorder, especially teenagers and children, do not feel safe. And so you have to develop that sense of safety and that sense of trust. And just working with that person for 3 months isn't enough time. 6 months isn't enough time. So we're really looking at client-centered, a true Rogerian approach to practicing that unconditional positive regard, validating those experiences, even when some of those are truly because of it's part of their symptoms, delusional thinking. And so they're experiencing psychosis. And so you're helping to provide that education to the family. That's really important for them. So working with those, when you're talking about minors, working with those caregivers is imperative to be able to do this. So that these episodes don't escalate intensity and frequency at home. So as you're developing these things, and as they're the getting closer to becoming stable with medication, then you're able to bring in some other approaches like CBT, and even DBT has been helpful. And so the first thing you have to do is you have to get to a point of stability before you can work on anything else. But while they're working on that, you can help to develop trust and safety in that relationship with you.
And Jen, once that has been, that trust, that safety has been developed, there also needs to be mood stability before
Mhm.
any of those traditional therapeutic interventions like CBT can be used. Can you explain why?
Yeah, so they can't use those skills that they're learning if they're not stable. They might not have, if they're in a depressive episode, or you're seeing high anxiety as well, and that can happen in depressive episodes as well as in mania. So regardless of what mood state, they're just not able to use what people call use your coping skills. And that part sort of irritates me a lot when I hear it. They just need to use their coping skills. They cannot access those in those moments when they're experiencing those mood episodes. They cannot access that information. And if you remind them, they'll go, oh, yeah. And they may have this connection or this memory, but they're not able to implement those things at that time. It's only when they're well that they're able to actually utilize those skill sets. And people might go, well, what's the point? The point is so that they can maintain stability, so that they can recognize when they're slipping into a possible mood episode, whether it is mania or it is depression, that they're able to go, okay, I know what I need to do in order to possibly stop that from sliding even further.
So there's a final question here that I want to get to, and I just want to point out to everyone that yes, we were supposed to end 10 minutes ago, but because we had so many great questions, it has caused us to run over a bit. So if you do need to leave, that is okay. We understand and respect your time and appreciate you being with us. This will be posted on our YouTube channel later this year, and you can find it there. But we will take just a couple more minutes to wrap up here. And the question, well, one question that we keep getting is, so what do we recognize, what do we need to do for parents? Again, if you have a question, please don't raise your hand. Please go ahead and put it in the Q&A. That's where we're going to be answering questions and receiving comments from. A question that keeps coming up is parents want to know what do parents do? How do we help parents who are experiencing living with children who have these disorders? And one thing I will say is that we have a class. It's called Palliative Parenting, and it was designed specifically for parents whose children have mental health challenges. It is applicable to bipolar. It is applicable to borderline. It's applicable to reactive attachment disorder or PDA or DMDD. It doesn't really matter. It's for parents of children who have mental health challenges. And so that is a great resource for parents, not only to learn new strategies, develop new perspectives, but also to get support from other parents, because it is a community class that's conducted online, and folks are able to connect in real time with other families who are living with the same challenges. So that is available to anyone. You can get information about it from our website. It is under the Programs and Services tab on our homepage. So that being said, there's a question here that is about whether or not there is a different gold standard for assessment for borderline personality disorder than there is for bipolar. My understanding would be that the gold standard is really about the tools that we use as clinicians to identify accurately what the diagnosis is. And it's generally going to be applicable to all diagnoses, regardless of what they are. But is there something else that think, Emily, is should be a part of sort of standard operating procedure when considering borderline personality disorder?
Especially in teens, we would include information from the parents who would give you information about their experience and their reactions to like how things go in the household. But really, the way that Jen kind of described their process sounded like perfect, right? Because you're going to need to get the comprehensive clinical interview. There's screeners like the McLean borderline screener. There's the difficulties and emotional regulation scales that we use to kind of better understand what's showing up. We get the family history. We understand the different things looking for those areas where invalidation might be occurring. And we definitely want to get a hold of the psychiatrist and have in-depth conversations about like what their history has looked like and their experiences.
So I will say that I anticipated that there might be some gasps from professionals in the audience when talking about the gold standard for diagnostics. And I get that in part of this is that there are challenges in that insurance companies want a diagnosis right away. And so there's pressure to do that. I know that when I was in a medical setting at a medical practice, and when I was in private practice, I would put a caveat with parents that this is what it is consistent with at this moment in time, but I'm still gathering information. So the diagnosis is likely to change as I'm getting to know you and your family and this child, and as I'm receiving more information. And so also administrators want to, in practices, want to fit in as many patients or many clients as they can within a day, and sometimes limiting the amount of time that you might have. So I do understand that there is some concern about, well, I'm not sure if I have the ability to do all the steps or all the things that is going to ensure the highest degree of accuracy that could be possible. And so that's why we have a diagnostic consultation service that is available not only to parents and families, but it is also available to providers to reach out to us to say, hey, can you help us with this process? Because I just don't have enough time to be able to do this as thoroughly as I would like to be able to do.
That's right. We do that. We do that for providers as well, so that you have the diagnostic information that you need um, when you don't have the time in your schedule to do all of that legwork yourself. Because we recognize with the mental health crisis in this country, providers are overwhelmed and they need support as well. And so we do that as well. Someone is asking for the names of the screening assessments used for bipolar again. They are the Child Bipolar Questionnaire and the Janie and Jeffrey Illustrated Interview for Children, both of which can be found on the website of the Juvenile Bipolar Research Foundation, which is jbrf.org. Okay, well, that is going to be it for today. Thank you so much for being with us. I want to mention a couple of things to everyone. One, we are having new webinars and clinical seminars next month. Our webinar will be on September 17th, I believe, and it is called Therapy 101, and we're going to be talking about therapy, why people go, what to expect, and how to talk to a therapist about the problems that you're having. And then we will be having an encore of one of our most popular clinical seminars from last year. You can go check out information and register for these free events on our website, cmhrc.org. They are under the free resources tab on the menu. I would also like to remind everyone that we have a book club that meets every month, and folks can find out about that on our website under the Programs and Services tab on the main page menu. I also wanted to share information that people have been asking about. Resources for parents. We have many resources in terms of our programs, our services, and our free resources on our website for parents. One thing I would encourage is folks are asking about parenting support. We have a parenting class that is 9 weeks long. It's called Palliative Parenting, and it provides additional support and perspectives, and allows parents to not only learn new strategies on how to parent, but children with mental health challenges, but also new perspectives that they can take on the experience of symptoms and behaviors. And almost most importantly, it is a way to connect with other parents who are also experiencing the same thing, and to develop a sense of community and break down that isolation. Emily, I want to thank you so much for being with us. And if you would like to share anything with our audience here at the end, please go ahead.
Yeah, sure. So you talked about parent support. Our programs do offer parent support throughout the process. In fact, our parents learn the skills right alongside with our kiddos. They get a lot of support. They also get phone coaching, which means parents can try something different along with their kids, because the kids get phone coaching too. If you guys want any more information about our programming, what the DBT programming to treat borderline personality disorder looks like, both for adults or adolescents. We even have a child DBT program started very soon too. You are welcome to reach out. My website is www.evolutionofselfcounseling.org. And I also work with the Greenville DBT Collective. And this is a group of businesses that come together to make up that consult team to keep us all in check. Their website is gvldbtcollective.com.
Wonderful. So thank you everyone for being here. Thank you, Emily, for being here. I'm sure we've all learned a tremendous amount from this fantastic conversation. We look forward to seeing you again and having you be a part of our community. So thank you everyone and have a wonderful night. Bye.